Hi, Jerry Pal listeners. Just want to do a special shout out in the beginning to all of the recent donors to the Jerry Pal podcast. If you're interested in donating, go to the Jerry Pal website and just click that big blue button.
Special thank you to Margaret Leung, Huey Lin, Ken Longa, Susan McFadden, Carrie Rubenstein, Marissa Galicia Castillo, Cara Bischoff, Kate Mesrich, James Tulsky, Louise Aronson, Asher Edwards, Mark Apfel, Michael Bordowski, and Meg Walhagen. Thank you very much.
And on with the show. Welcome to the Jerry Pal podcast. This is Eric Guidera.
This is Alex Smith.
And Alex, who do we have with us today?
Today, we are delighted to welcome three first-time guests. We have Sarah Nouri, who is a palliative care doc and researcher at UCSF. Welcome to the Jerry Pal podcast, Sarah.
Thank you.
And we have Hillary Lum, who is a geriatrics and palliative care researcher at the University of Colorado. Welcome to the Jerry Pal podcast, Hillary.
So great to be here.
And we have LJ Van Scoy, who is a pulmonary critical care, advanced care planning researcher at Penn State Hershey Medical Center in Pennsylvania. Welcome to the Jerry Pal podcast, LJ.
Thank you so much for having me.
On today's podcast, we're going to be talking about improving equity in advanced care planning. But before we jump into that topic, I think somebody has a song request. Is it you, Sarah?
It is. I would like to request The Friendship Train by Gladys Knight and the Pips.
Why are you picking this song?
Yeah, I picked this song because it's all about community and love and justice, and I think it's in line with our theme today. And I love Gladys Knight.
Yep, great choice. Here's a little Gladys Knight without the entire soul band backing me up. There we go. Calling out to everyone across the nation. Said the world is in a desperate situation. People tell me what you need. We've got to learn to live with each other. We've got to learn to live with each other. No matter race, the creed, or the color. No matter race, the creed, or the color. What the world needs now, what the world needs now is love and understanding. Love and understanding. Get on board the friendship train. Choo, 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 choo.
Choo,
Fabulous.
That was wonderful. Even without the full soul band backing.
choo, choo. Well, thank you, Alex, for that rendition. Okay, we're going to be jumping in the topic, advanced care planning, especially how to improve equity in advanced care planning, talking about group advanced care planning, a lot of stuff around it. I'm going to turn it to LJ first. LJ, a year ago, I heard from some prominent members of the palliative care world that, advanced care, we should move away from advanced care planning. Advanced care planning doesn't work. I'm not sure if you read that article and whether or not it's changed your mind or whether or not you want to do any more research in advanced care planning. Your thoughts?
Definitely saw it. Definitely read it. Remember where I was when I read it and saw it. And it was, it's a great article. Got everybody thinking, and it certainly got everybody talking. I credit that article with making us think very sort of introspectively about the work that we're doing and why we're doing it. But it did not sway me to want to throw the baby out with the bathwater and not want to continue doing work in advanced care planning. I think that for me, it just sort of reaffirmed stuff that I felt that we sort of already knew, is that this is really complex and that it was really difficult, and that outcomes that we choose to measure are probably not the right ones, or difficult to measure, or a combination of both. And if it was simple and easy to solve, then it would have been solved by now. So that was kind of where I canned on. I don't know with Hillary and Sarah, what you guys thought.
I certainly agree. Lots to think about. And I've really leaned in from my perspective as a primary care geriatrician to hearing from what my patients and their family caregivers are asking me for and asking me about. And they're asking me about how they can prepare. And so that's really led to a lot of thinking about both in the moment decision making and also preparing oneself, preparing with other people around you from your community, and also talking with your healthcare team members.
Yeah, I couldn't agree more with that, with both of you, really. That totally impactful article. And I appreciate this chance to really think critically about what we're all doing in this field from a research standpoint. And that's also kind of where I leaned in, Hillary, was hearing from patients and also hearing from our communities that we're serving, and just hearing that this is something that people at a community level wanted to learn about and wanted their communities to be engaged in is really impactful, and I think speaks volumes to advanced care planning's role or importance as we move forward.
Could I ask a follow-up here? I'm hearing that the communities are asking for it. I'm hearing that loud and clear. What are your thoughts about the outcomes of advanced care planning? Because I know this is also controversial and has been discussed. Do you think we're measuring the right outcomes, or what outcomes ought we be assessing for advanced care planning?
I'll take that one. I feel really strongly that we are not assessing the right outcomes in advanced care planning. And I think that's part of the problem is that I think we do this in a lot of science and a lot of research and in clinical medicine too. We try to hone in on what is the one outcome, what is the one thing that we are looking to improve or affect. I think that, for advanced care planning, it's more about process than an action or behavior. I know a lot of us in research, we use these, conceptual models, or we work towards behavior change, or we want advanced directive completion to be the outcome, which is, I'll speak for myself, and I know Hillary too. I don't know, Sarah, in your research, but we measure advanced directive completion as our primary outcomes in our research trials. And that's sort of, probably not the best approach, but I think the more important part of our trials and of our work is some of the qualitative and the mixed methods and the complex social processes that we observe and try to improve upon with regards to communication and process. So it's hard to measure those things, which is why we don't. And I'm excited that there's different opportunities and fields and ways to measure things that are perhaps a little more messy, and they don't come tied up in a nice little bow. Did you do your advanced directive? Yes or no?
Right. Yeah. Hillary or Sarah, thoughts on that?
Yeah, I similarly feel focusing more on the process, the qualitative, kind of from a research standpoint, the qualitative information that we're getting from folks. And I think it's something that I'm kind of actively thinking about and struggling with, because I think working on projects in the community, there's been multiple limitations around kind of what to measure, and also how to measure, and how to keep people engaged in that process of kind of even measurement or reporting back. And so I think it's an important question, and I think it might be different depending on the context and the setting too.
Yeah.
Mm-hmm. Hillary, what should we be measuring?
Oh, I get the easiest question. I feel that tension because it seems to be related to who I'm trying to measure it for.
Right.
Am I measuring it for my health system? Or even within that, we're part of Primary Care First, a value-based payment program. So am I measuring it for that specific clinic level quality metric? Or am I measuring it for my research study? So those all differ. And then I also have to lay on pragmatically, can I even measure it? Is it feasible to measure, as both Lauren and Sarah have been saying? So I have not given you an answer. I see us measuring choice of a medical durable power of attorney. That's what we call it here in Colorado, choice of a trusted person as a starting place. And then I also see us measuring advanced care planning documents on file in the health system. So that's not where I want us to be. That is the current state of where we are right now.
Where do you want us to be?
Oh, goodness. I think it would be helpful to have a person level report, which maybe we're getting closer to in terms of heard and understood, that someone has had a chance to think through what matters to them and do the preparation that is the amount that they want to do at that time, and that it has been communicated with the health system, though that's flawed and anchors it to the health system also.
Because it probably doesn't help if they felt heard and understood, and we've documented that, but we do nothing about it, which is, if you look at like Dartmouth Atlas stuff, is that it's not just personal preferences that drives medical care. The healthcare system drives medical, where you end up, which hospital, which state you live in.
But I'd challenge, so it's okay to disagree with each other on this podcast. I'm going to disagree with Eric here. Terry Freed had a wonderful commentary in JAGS where she argued that we need to move away from these, like, does it actually affect the type of care that a person receives, and move more towards did they feel heard and understood, psychological outcomes in the caregivers, that the caregivers and whether they felt like they'd been listened to, and have less like depression, PTSD, anxiety after the death is actually more important than whether, the health system got the document and, care plans were altered and they stayed out of the ICU.
Yeah, I would agree. I mean, the problem isn't that most of the time we don't even look at the advanced directive, which is the problem, right? With advanced directive and thinking about it. So I love the idea of like looking at the caregivers. I guess my question was more as we think about process is, if we just look at one side of the equation, the process, does a family member or caregiver feel understood, but the healthcare system doesn't change at all and ignores what's important to people? Is that really helping?
So thoughts from our guests on this disagreement Eric and I are having?
I was also going to reference Terry Freed's commentary around moving towards thinking about caregivers and surrogate decision makers. And I think some of the findings that have come up in my research are that advanced care planning really serves as, or can serve as, a tool for agency and empowerment, and a kind of way to navigate a health system that's built on and with a lot of structural racism. And I think in that way, as I reflect on that, I think, well, I don't have a good answer on how to measure any of those things, or at least throughout a process. But I think as we think about it as this tool for agency and how you can kind of bring I think you had a recent episode with a few folks on your inner circle. And I love that phrase. But as you bring your inner circle into your care, how does that feels like an important group to be assessing in terms of psychological outcomes and kind of what their experience with the process is like as they're navigating illness and serious illness.
LJ, you're going to add to that?
Yeah, I was going to add, one of the things that I think that this whole debate has really done is taken what some of us in research have been discovering, or that we maybe take for granted in our qualitative data, for example. And it's really brought to light the fact that like feeling heard and empathy and feeling like they were listened to is not something you can sort of measure necessarily quantitatively. And so one of the things that was really, I thought really interesting in a research study, that wasn't my research study, it was Michael Green and Benny Levi's research work. And I was doing the analysis of some of their interviews. And what we discovered in that project, it was a long 8-year project of a decision aid, very cognitive and sort of knowledge focused. But what was really interesting is when we started analyzing these interviews, people were not talking about the same thing when they were talking about advanced care planning. And when we talked about what is a surrogate decision? We couldn't agree. We couldn't agree between our 15-person research team and our research participants couldn't agree. And then we were like, well, what is a medical decision? And we couldn't agree there either. Well, what's a major medical decision? And so it actually, this little paper generated out of it. I remember thinking when I was writing it, I was like, I don't even know where I'm going to publish this thing. Like, who's going to care about this whole conceptual thing? And then boom, these papers hit, and it I'm really grateful because now that paper got right into JAMA Network Open because it became so important, because the way that we conceptualize and the way we think about this and the way we define it is really different than how our participants and how our patients are defining it. And I think that's one of the reasons that we've not done a very good job in research around
how are patients defining it?
Well, so they were really conflating surrogate decision-making with advocacy. So if we said, like, did you make a decision while one of your loved ones was in the hospital? They would say, oh, yeah, absolutely. That, I made sure that, when they wanted to hang, vancomycin, I told them, no, they couldn't hang vancomycin. They needed to pick another antibiotic because of reason X, Y, Z. And it was sort of more like patient advocacy to say, like, vancomycin hasn't been good for this patient in the past, or, it wasn't really a medical decision. In the way that we would think about end of life decision making or, CPR, no CPR, those kinds of decisions. It was more about just like advocating, like, well, I think he should get his pain meds 30 minutes earlier than it's scheduled. And that's not necessarily what we're talking about with advanced care planning.
Yeah.
It's funny because I was just going to say, I would advocate that in many ways, like I was thinking about Rebecca Sudori's new kind of conceptual model around care planning, the care planning umbrella, and thinking about like, even at that level of kind of decision making, that perhaps that is, I was just going to say, it's funny that you said none of you could agree, because I feel like maybe that is kind of part of this medical decision making. And that is, I think, some of the advocacy that I've also heard from patients and the kind of advocacy that they're hoping for from their inner circle. And so it's interesting I agree. There's so much disagreement or just different perspectives on what that is and what it means.
The other thing that came to my mind reading about this debate is often it's like, who should we be targeting with advanced care planning, or whatever term that we want to use it? Like, probably not like healthy younger people is the argument. And I wonder, when we think about targeting particular populations, not just how seriously ill they are, how have we done so far with targeting advanced care planning amongst all different populations?
I think that's a great question. I think all three of us are probably ready to answer that to some extent. I'll just say that I think what we know is there's been so much great advanced care planning research, and at many levels, at an individual level, at a health system level, at a policy level, and still there are some big disparities that persist. One of the things that I've enjoyed doing as part of my research is working directly with communities from the get-go to try to answer this question. And I think some of what a lot of what came up in some of my recent work is that within different populations, there are groups that may benefit from advanced care planning, even if they're younger or healthier, like folks who come from perhaps have a more vulnerable situation, like folks who are trans, identify as trans, or of the LGBTQI plus community, that there's a special need for that population, even within already kind of underserved or systemically groups.
Is that because the traditional surrogacy hierarchies often don't work for those communities?
Totally. And people shared stories around knowing, a trans woman who was buried as a man after they died, because ultimately the people making the decisions were that person's family, and that family was not necessarily a trusted network. And so I think part of that around surrogate decision making, and also respecting wishes and identifying the people that really are your trusted network. So I think there are definitely, to answer your original question, Eric, that there are populations and maybe even populations or groups within certain populations that the three of us are working with that have potentially special needs around advanced care planning.
I've often been
on to Hillary or LJ. I'm sure you've got a lot to say too.
I've been thinking about your question, Eric, and whether we need to develop tailored interventions, or is it about accessibility? And the recent work that I've been doing has been more on the aspect of accessibility or inclusion. Is it possible for as many people as possible to access the type of intervention that we're offering? And in that process of seeing whether individuals desire to participate in something that the clinic is offering or something that an organization is offering, is it appropriate to have flexibility to adapt the intervention? I don't know that there's enough time or money in the world to develop specific interventions for every specific population. So I've leaned more into the adaptation and being mindful of context and cultural aspects, needs, preferences, and that can get a little bit into creating something together or adapting something together with the members of the community who we hope are interested in sharing this with others in their community.
Yeah. And particularly, you've done part of that accessibility is group visits. Really, all of you have. Is that what you're talking about?
Yeah, in that
around.
I've looked at group visits as actually a means to integrate, hopefully, advanced care planning into primary care in sort of my area of interest, where I'm not actually developing any specific new decision aid or a new advanced care planning intervention. I think one of the strengths of a group visit is that you can choose the materials that you want that are actually most helpful to the individuals who come to your clinic. So I think it's a complex intervention for sure. Groups are more complex than one-on-one, though may have sufficient opportunity to tailor to the individuals who are part of your clinic or part of the community coming to your group.
Mm-hmm. And just to be clear here, the groups who come together do these advanced care planning, they might be from a clinic, but they may not know each other at all. In fact, they're less likely to know each other than to know each other.
Absolutely true. And we really love the group dynamic magic, the special sauce that I think really embraces that people can learn together, in part because they come with different questions and can learn from one another and have different cultural backgrounds. And they bring all of that there. And in fact, the facilitator is not the teacher. And instead, in facilitating the discussion, there's actually increased agency of the people who are there. Our groups end up being 2 in a row, and it is great to see how when they come back for that second group, they are really even checking in with one another, because you're right, they didn't necessarily know each other coming in, likely didn't, but are checking in with each other.
Wow. So what's a question that would be asked in a group?
Very pragmatic. What do you do if you have your phone, but the EMS doesn't know your documents? Just like those nuts and bolts aspects, because some individuals have a sense of, okay, it's all about documents. So we try to broaden beyond that. Mm-hmm. And then individuals will still have questions of really, how can I help my wishes to be known? And we get to spend a lot of time thinking through that in different scenarios that are real life situations that the individuals bring in with them to the group.
And do you use any specific tools that are...
Yeah, we've been doing groups over the past 10 years and have used a number. We've used the Conversation Project Starter Kit, including actually making a 2-page version instead of the larger one. We've used some resources from Australia, some great videos that have fit well. And we've also used Rebecca Sidori's Prepare for Your Care. In particular, we use the flexibility step, because that's often a concept that many have not thought through.
Yeah. That you mean, like, how much flexibility would you want your surrogate to have? These decisions are fixed, please don't change them under any circumstances, or my surrogate should have a lot of flexibility or leeway, to adapt to the circumstances and do what's in my best interest at that time. Is that what you're talking about, Hillary?
Yep.
Yeah.
And Hillary, you're focused, it sounds like, group work in a healthcare system, so in clinic. I know both Sarah and LJ, you're doing this in the community. LJ, do you want to describe you have a big NIH supported project around this, group visits in the community?
Yeah, well,
I guess not group visits, but
I wouldn't call them group visits.
Group advanced care plan. That group. What would you call it?
Well, we call it Project Talk, and the which is just, our name. But essentially, what our work is really using one tool. Well, actually, that's not true. It's a trial. We're comparing 2 different tools, but a lot of the work that led up to this, we were working with the Hello game, which is it's very, actually, as I'm listening to Hillary, I'm like, it's so similar to what you're doing, except that the Hello game is really just like it's a set of open-ended questions that participants can come together and like play this game. There's chips and there's rules and there's a coin flip and a quote winner and a quote loser at the end. No losers, of course, but it's really like brilliantly designed around like game design theory and some psychological safety tools. And what's really interesting about it is that we don't bring in any knowledge. And what Hillary was saying about how like the people, they come together and they check in and they learn different things. They come in with different questions. We actually find that in our group activity, which is in one arm of our trial, we're testing the Hello game, where it's, these open-ended questions, and people may bring their family, they may be playing with strangers, and it's very user-generated. We don't push any information at them. It's all generated within the context of the game. And so people feel very comfortable and very safe, and, there's no didactic and there's no lectures and there's no PowerPoints. And it's this very like gamified approach that we've found, in the research we've been doing in this game for like the last 10 years, people say over and over how just having it as a game, calling it a game, makes it a safe environment and a non-threatening forum and a safe structure for them to share and learn from each other and explore. So people will like have new, like, oh, I never thought of it that way, when they're going around answering the questions and then listening to other people as the game is played. And so the Project Talk trial is testing that approach versus a more traditional, which equally valid, which has more of that knowledge push. We're actually testing the Conversation Project toolkit in our second arm. And that toolkit is great because it does provide knowledge and background and stories. And there's, a PowerPoint didactic, and it's sort of a more traditional approach. And so the trial is really looking to see, does the gamified approach versus a traditional approach make a difference? And then we have a control arm as well. So we'll be able to test all the tools against each other.
What's in the control arm? Like watching
the control
a TV show?
arm, no, it's another
Blackjack.
game. It's called Table Topics. It's an awesome tabletop game I play with my kids at dinner. And it's the exact same structure as the Hello game, except instead of open-ended questions about like advanced care planning or end of life, they're like silly questions like, what do you love about your hometown? Or, like more icebreaker conversations. So it's an attention control so that they're playing a game, they're doing the same structure, they're having the same camaraderie in our control.
And where are you in the midst? Are you in the midst of this trial? Are you getting close to done?
Well, we just surpassed a big milestone. We just passed halfway. And so the trial is conducted all over the US. And so we're traveling, we send a research team out to partners in the community. So we go to churches, we go to hospice agencies, we go to public libraries, we go to health systems, sort of anywhere there's like a practicing clinician that wants to bring advanced care planning into their community. We have Spanish-speaking research assistants. We work in underrepresented Black communities and low-income white rural communities. We're hopefully doing some Native American communities. And so we're about halfway through and still recruiting hosts. So,
and you had a message for our listeners.
Yeah. So if anyone is interested in hearing more about the Project Talk trial, just visit us at projecttalktrial.org. As we approach our second half of our project, we're really excited because my goal is to hit every one of the 50 states. And I think we're at like 30 states so far. So,
oh, wow.
We'll have a link to that on our show notes.
Yeah,
just real quickly for our listeners, if they're interested in this, how much work is it for them to be a host?
So it really depends on sort of the work that you've already done. So if you're already out in the community and you already have your networks and your connections, it's not a lot of additional work. And in fact, it probably saves you a lot of work. We provide a $300 stipend for like food and marketing or whatever. We provide all the materials needed for the event. We provide all the marketing materials. Really where the legwork comes in is, getting people through the door. And usually we want like 20 to 50 people to come to one of our group events. So some people find it to be like, oh my gosh, 20 people is a breeze. Like I could do that in my sleep. And for some, it's a heavier lift. So we've found that it really depends on your experience and those sort of fingers that you have in the community.
Yeah. And before we move
and even though we're on JeryPal, it's actually not funded by the NIA. So this is individuals 18 and up.
Yes, that's true.
Does not have to be
Thank
only
you for
older
that,
adults.
Hillary. Yes, this is a NIMHD Health Disparities Project.
And it would be okay if it was a geriatrician, say, who had a
Oh, of course.
Older patient panel. But before we move to Sarah, LJ, just sticking with you for a moment, one of the key aspects we want to cover on this podcast is equity. And I know it's early and that you haven't completed the trial, but any lessons learned at this point or thoughts from you about adaptation to specific populations or groups or communities?
Oh man.
Yeah.
How much time do I have? So one of the things that our team is really learning, we're a big team. We're partnered with the Hospice Foundation of America. So we have a very national reach, and we've been in communities all over the US, and we're finding that each community is really, really different. In our, we're doing 15 Hispanic communities, and there's different dialects. So there's Mexican Spanish and Dominican Spanish and, Spanish from Puerto Rico. There's all different types of Spanish speaking dialects that you have to incorporate. And so like Hillary was saying, like you can't possibly take one tool and adapt it for every context and every culture. And so I think really important is the field of implementation science and learning how we can take our tools and adapt them for the unique cultures. But what we are finding with the tools is that particularly in with some of our host interviews is that when they make those little tweaks and turns to the intervention, it's well received. All of these tools are acceptable. The population is so grateful to have these opportunities, to have these stigmatized conversations. And it's okay to have these conversations. And we found that no matter where we go, people are really thrilled to have us. So it's been really rewarding for our team.
Mm-hmm. And sorry, one more question. I can't resist. What outcomes are you looking at?
Yeah. So the main outcome is advanced directed completion. And that is, again, a hard measurable outcome. But one of the ones I'm most excited about is a methodology that I designed with my communication partner at Kentucky, Allison Scott, who we're looking at communication quality analysis. So we're looking at the communication quality that results when people have their group conversations over tool number 1 versus tool number 2. And I'm really excited to learn, and focus on communication quality as an outcome as opposed to behavior as an outcome.
Mm-hmm. Great. That's fascinating. All right. We should turn to Sarah. Sarah, I know you've got, we have several of your published papers and abstracts, and you've done work, as you just said, in the LGBTQ community. You've done work in Black community. You've done work in the Latinx community. You've done work in the Chinese American community in San Francisco. That's a lot of ground and a lot of topics. And like LJ said, how long do we have? We'd love to hear about your research. And you've talked a little bit about the importance of equity and tailoring these, and is really starting from the ground up in what you're trying to do here in advanced care planning. What lessons do you have you learned from these terrific studies?
Thank you. Yeah. First I want to say I'm very excited about LJ's projects because I think actually a lot of what we've learned in our work is some of the similar takeaways to LJ's, but with a really different methodology and approach. And so that's reassuring.
Awesome. Yeah, that's great.
Ways. Yeah. We basically engage in this community-based participatory research project. So very local with several communities here in San Francisco. And I would say, so we actually, they were involved from the ground up, kind of equally and equitably. And part of our work was doing capacity building with different communities and community-based organizations to kind of continue the work. But what we learned, I'll say some big takeaways are that, similar to what LJ said, so safe, trusted spaces are really, really important. And so there's value in kind of taking this out of the healthcare system for some folks and having it in a trusted community setting.
What's an example of a trusted community setting?
Yeah, well, so that's a great question. I can say how much time do I have for that question alone. It was different in every community, but I'll say in general, some senior centers, housing, like Lady Shaw Senior, some of the SROs in town. And also in the Black community, Black-owned businesses were really highlighted as a trusted space. So whether that's a restaurant or a jazz room, or, there were several that were specifically named here in SF. So that was very different in different groups. But part of what made it trusted was not only the space, but also the people leading the event. And importantly, for those folks to be part of the community themselves. And then the other big takeaway was that in terms of your question about tailoring materials or that tension we all feel, is that, we actually all the communities decided to use existing advanced care planning materials that, like Hillary and LJ have said, have really been tested and evaluated so many times and shown to be effective. And so things like Go Wish, there was a similar desire among folks to do, to have a game or as sort of an icebreaker, a way to facilitate a difficult conversation. So games like Go Wish, or in the Cantonese speaking community, the Heart to Heart cards, and then Prepare for Your Care, 5 Wishes. So using these existing materials actually works. A lot of what was different and what was done differently in these communities that I worked with was really around the marketing, I guess, more than anything. It's really, how do you attract people to this conversation, and how do you design an event that breaks the ice, that makes it, that kind of normalizes having this conversation? And how do we take advantage of the fact that we've got a group of people, like Hillary was saying, who can learn from each other and who also see, a peer from where they live in their same building and say, like, oh, well, this is my neighbor, and if they're talking about this, I could be talking about this too. And so just creating that kind of peer-to-peer network. I think that a lot of the tailoring is not necessarily about the materials that we already have, but really, again, going back to what LJ said about the implementation and how do we get the word out to people about advanced care planning? How do we talk about it, and how do we get people engaged in it in a way that feels safe and productive? And a lot of that really feels like it's around marketing.
Like delivering. It's not just marketing, but like delivering, I think.
Yeah.
Right. Yeah. And I hear both of you talking about, all of you talking about creating safe spaces, and that, sort of cognitive psychology, which we've talked about in this behavioral economics, on this nudges, in lay terms, that there's this social expectation that if my neighbor's doing it, as you just said, Sarah, then I should be doing it too. I wonder what pushback. It can't all be positive, right? There's probably some pushback about this. I'm interested in hearing about that, like concerns about marketing advanced care planning to communities that feel like we have been subject to so much systemic racism, particularly in healthcare, where there have been historic and present gigantic inequities in care. Should this really be the focus? I don't know. What are you hearing from communities in terms of countervailing perspectives?
Absolutely.
Sarah, go ahead.
Okay, so I was just going to jump in to say that I think part of, and there may have been some bias in kind of who was working with us realistically within the communities, but there was definitely a lot of conversation around that. And at the same time, that folks actually viewed advanced care planning as a way to counter a lot of what you're talking about, Alex, like as a way to counter the structural racism, as a way to counter or protect folks. Like in the Black community, a lot came up around young Black men and Black individuals dying much earlier, having a lower life expectancy, being subject to all kinds of violence, including within our healthcare system. And that advanced care planning was actually viewed as, oh, wait, this is something that might give us a voice. This is something that might actually give us some agency around decision-making in general, not just kind of end-of-life focused, but really decision-making throughout the course of someone's health experience.
I also thought it was really interesting because that was the same article that talked about the importance around agency and protecting intergenerational wealth.
Yes.
Which I usually don't think about or see when people are talking about advanced care planning. They usually think about medical decisions and end-of-life care, but not financial aspects.
Yeah, that was a really interesting and I think really important information, going back to one of LJ's points, I think early on, about how do people define advanced care planning and what does it mean to different folks, different communities. And it was clearly came up that really, when we talk about advanced care planning from a health standpoint, we should be thinking, and I think this is something I've taken into my clinical practice of, we should be thinking about planning more broadly, really. And I know a lot of our social work colleagues and our nurses, I think, at least in our practice, do a lot more of, but I think we can do more of as physicians too, of including that as part of a bigger life planning and estate planning. And that did come up as a really, like, maintaining intergenerational wealth or building intergenerational wealth was a super important topic that came up in the Black community.
Mm-hmm. And Hillary, you've been doing this for 10 years. There must be some patients for whom group advanced care planning is not a good fit.
Yeah, that's exactly where I thought your question was going. And then it went about, pushback on advanced care planning overall, which is a separate topic. But I definitely started this knowing that groups are not the answer for everyone. And I don't expect them to be. I introduce this to clinics who might be interested in bringing this on the same way they might bring on a diabetes group visit or centering pregnancies. We know many federally qualified health centers in our area that have those prenatal centering pregnancy group visits. And I approach it the same way, that a group is not for everyone. And yet it can be something that if a clinic wants to take on implementing it, can really be effective, efficient, and I also actually think it meets the quadruple aim in that as facilitators, it's really meaningful to be present in these conversations.
Totally. And, the pushback, Hillary, it's so funny you say that because I was actually just at an event, one of our supplement events recently in a group with Alzheimer's disease. And I was there just sort of observing the protocol and some tweaks we had made. And I was just so glad to be back out in the field because I was listening to these two wonderful people with mild cognitive impairment from this really impoverished area. They were playing the hello game and they were having this conversation and they were arguing with each other about the right answer and the wrong answer. And no, they were just talking about end of life issues and, really, if you're going to be on a machine, you want that. And they were just arguing. And the facilitators, I could see our staff, they were a little bit uncomfortable because it was oh, where is this going? And I was like, this is awesome. This is just such good work that these groups do. And I think bringing together people that may have different ideas or perspectives is uber, uber important. And they left. It was great. It was just such a good experience.
I want to be mindful of the time. Alex, any questions before I go to my last one?
Go for it.
I want to hear from you again. We're going to do the magic wand question. If you had a magic wand and it has to be used around this topic of advanced care planning, what would you use that magic wand on right now? Hillary.
Right.
Yeah, I am going to pick up what Sarah was recognizing, that from my patients and their families' perspective, especially older adults with serious illnesses, advanced care planning is one sliver of it. There's so much additional anticipatory guidance, unmet opportunities, a need, a thirst for resources, especially resources that actually resonate and would be things that they could see themselves being able to access and use. That's the magic wand. Advanced care planning is a start. It's one entrance in, and it's the one perhaps most accessible to me in primary care, but it's part of a bigger ongoing need.
Sarah.
Yeah, I love Hillary's magic wand. I think kind of along the lines of some of our discussion that I hope we can continue to work to really decolonize advanced care planning and take it in the work that I think all three of us are doing to try to reach communities that are experiencing disparities despite so many interventions. I hope we can continue to find ways either as researchers or clinicians or advocates in the community to really decolonize this process and framework and find ways to continue to make it speak to people so that more folks are engaged and feel empowered through it.
Speaking of Alex, this is not going to be our last ACP podcast on equity. And
no, we are planning listeners, get a sense of how far out we plan. This fall, we're doing a podcast with Fayron Epps and Karen Moss about advanced care planning in African American churches. So listen for that. LJ, your magic wand.
If I could wave my wand, I would find a way to say what it is. Like, what is it that advanced care planning does for people that's helpful? And I think if I had a magic wand, that's what I would want to put into a box that we could measure and report and say, here it is. This is the smoking gun. This is why we should be doing this. And we haven't found it yet. We've certainly, I've tried. We've done this integrated variable that includes all these different types of outcomes, which is a whole other
I guess it's with that outcome, it's why we should be doing this or why it doesn't work, right?
Yeah, exactly. Well, but we know, but this is what I'm saying is that qualitatively we know, and I'm sure that those that authored the articles would probably agree that there's benefit, right, in doing this work and having these conversations. It's just, what is the benefit? How do we measure it? And what is it? But I have no question in my mind that it has benefit. Just that magic wand is what we need to figure out what it is.
Yeah. Well, I want to thank all three of you for joining on. But before we leave, I think we got a little bit more of a choo-choo train coming this way.
I've got to tell you what the world needs now is love and understanding, love and understanding. Get on board the friendship train. Everybody shake a hand, make a friend now. Everybody shake a hand, make a friend now. Get on board the friendship train. Choo choo, choo choo.
Choo choo.
Love it.
Thank you, Sarah, for that song request. Well, thank you, all three of you, for joining us on this podcast. That was absolutely fabulous.
Thanks for having us.
Thank you.
Have a great one. This was fun.
Thank you. And all of our listeners, thank you for your continued support. And we'd like to thank everybody who's donated more than $250 over the last year, including
Matthew Schuster, Daryl Owens, Susan Nelson, Christopher Heck, Lindsay Yorman, Mo Razawi, Sue Borson, Carrie Rubenstein, Marissa Galicia Castillo, Cara Bischoff, Kate Mesrich, James Tulsky, Louise Aronson, Asher Edwards, Mark Apfel, Michael Bordowski, Dwayne Dobschutz, Fish Brandt, Kelly Strait, Daryl Owens,
×2,
Roseanne Leipzig, Elizabeth Chung, Amis Samoji, Harry Hahn, Nick Schneeman, Ed Mateen, Jeff and Lena Galbraith, and Himanshu Malhotra.
Thanks, everybody, for your support.
Thank you.